Hello, this is the last session of this INCAS Asia 2026. Our session is Injectable Reimagined from Filling to Regenerating. We don't have much time, so we have to hurry up. Speakers, please keep the time. All speakers have 12 minutes. I'll introduce the first speaker, Diane Duncan, very famous speakers. I don't need any explain, right? Diane will talk about a beyond the conventional skin booster, targeting telomere biology and dermal longevity via epithalon-centered regenerating signaling. Diane, please.
Oh, thank you so much. Um, it's an honor for me to be talking about this on the last set of lectures on the last day at IMCAS Asia. My topic today is targeting telomere biology and dermal longevity with epithalon-centered regenerative signaling. This is a really very sophisticated modality and I think well beyond the effect of traditional skin boosters. One of the interesting things that I've learned relatively recently is from this article in Nature. We note that aging is not a linear process. We think that things degenerate after the age of 30 at a steady rate year by year. But in fact, there are undulating waves or aging cliffs that we see pretty much between the age around the age of 30 and then again in the early 60s, and then again about 78 years old. And if we know where these aging peaks are, it's important to anticipate and do some preventative treatments just before these aging cliffs drop off. If we look at telomere biology, we can see that there are two paths that the telomeres can take. One is that in times of lack of stress, the telomeres remain long because there's not a lot of telomerase activity. One of the things that we note in the FOXO TERT or telomere regulating axis is that FOXO in times of stress is upregulated in the cytoplasm, while the TERT will suppress the telomerase. And of course, this makes you age a little bit faster. And so how can we modulate that? By controlling the crosstalk and enhancing the telomere expression. So the ETC3 cascade is basically a stepwise method of addressing this problem. We see antioxidant priming, and for this we use a compound called PQQ. PQQ is basically a complement to the mitochondrial stimulant CoQ10. And when we're using PQQ, then we can prime the cells to be more alert to the oxidative stress, and we use this as a primer. So in this particular program, you'll use a PQQ-containing skin booster once every 2 weeks to every month, and then for the fourth treatment, then this is when you treat definitively with epithalon. The biologic limits of energy-based devices, I think we all know these because energy-based devices can cause damage. We've gotten away from doing too much of an ablation type procedure and more of a biostimulatory procedure, but thermal injury can sometimes overwhelm the cellular capacity to heal. And if we look at boosting the regenerative capability, then we will enhance or have a synergistic mechanism in which the EBDs and the cellular capacity can be improved. For many years, we've been doing this with exosomes, stem cells, and other biologicals, and this particular system offers something that is easily injectable, has a nice shelf life, and doesn't require refrigeration, freezing, or the regulatory limitations of things like exosomes. So if we look at EBD synergy and shared biological support, I think that most of us in this room know that combination therapy is much better than individual or monotherapy, although you can certainly do both, and these skin boosters work well with or without biological support. So you can use ancillary things like exosomes, but they are definitely well tolerated in combination with energy-based devices. So step number 1, antioxidant priming. We will look at PQQ and energy-based device redox readiness. We all know that the energy-based devices will stimulate the wound healing cascade. So normally this is 4 steps. We have the hemostatic phase, the inflammatory phase, the proliferative phase, and then the resolution phase. If we use PQQ about the same time as we create the initial injury, then this will prime our systems to generate more of a ready secretome that can also enhance the TERT axis. So you're basically ramping up and developing a synergistic response. If we look at phase 2, epitalon, then this is basically almost a time-released, prolonged dermal remodeling. And because you're getting a little bit of activation of the TERT axis, and you will also see some diminution of secretory associated senescent proteins, or SASP, as well as simulation of collagen 1, collagen 3, decorin, fibronectin, and laminins. GHK copper, of course, as we know, is a really bioactive and regenerative compound. This is a tripeptide and is commonly used. I know in the US, people are basically injecting this in a DIY manner. They just buy it online. Not really a good idea, but I think that this is something that we would rather stimulate endogenously than using an exogenous approach. I'm going to skip forward in the inclusion of time, and so we do want to enhance patient practical outcomes. And the last thing I want to talk about is PLGA-based controlled drug delivery. The concept of this is basically a little carrier. It's not like a liposome, but a combination of glycolic and lactic acid. And you can use this in combination with the FOXO-TERT skin boosting. The PLGA basically contains mostly collagen 3, and it's emitted over a time period of 3 months. And so you only have to do 1 injection, but you get collagen 1, collagen 3, but mostly collagen 3, which we know is very deficient as we age. And this will give you active protection, bioavailability, and chronic release. So this is the way that it works. And you'll see PLGA, again, when compared with PDLLA or a liposome, you get quite a bit more uptake. The PDLA only gets a very low number of stars. Liposomes will enhance delivery, but it degrades or becomes integrated in the tissue all at once. So one of the interesting things about this particular concept is that once you inject, there's an interstitial response and there's a rapid uptake of whatever you've injected, unless it's protected by a carrier, such as the PLGA. This is a FDA-approved procedure, and you get these waves of sustained response and biphasic restructuring or scaffolding of the dermis. If we look at a dermal reconstruction trial, we can see collagen encapsulated with PLGA, as we described. And this is something that is programmable, so you can put other things in it besides collagen. So I think my time is up. Thank you very much for your time.
Thank you, Diane. Very informative knowledge to us. Next speaker is Iran Lobredo Vitas. She's a Philippine dermatologist, right? Yeah. She will talk about beyond volumization, tailoring bio remodeling, injectables for skin quality in skin of color.
Yes. Thank
Please.
you very much, Doctor. And thank you for those who are still here. Congratulations for this very well attended conference. So, I have no conflicts of interest to disclose, but I will tell you that this lecture is an educational review of literature combined with my clinical practice considerations and my experience. So, um, I'm going to focus on three main products that I use in my practice, polynucleotides and polynucleotides with HPT, hyaluronic acid complexes, and PDLLA. So by the end of this lecture, I aim to be able to differentiate the three molecules, to teach you how to design tailored treatment plans for skin of color using these three ingredients, and to integrate other injectables and other modalities to optimize outcomes while minimizing complications. So nowadays, I'm sure that all of us will agree that there's quite a shift in what our patients want. Usually, I mean, before in the past, patients would come complaining about lines, folds, volume loss. However, modern rejuvenation now is no longer just about filling. It's about improving how the skin looks, feels, and even behaves. And in skin of color, there are a lot of clinical constraints. We have a more frequent PIH, we have lentiginous, freckles, we worry about our pores and texture, and on top of that, a lot of Asians are concerned about downtime because anything that turns red or bruises can become pigmented. And even heat and inflammation can cause pigmentation. So our endpoints are also quite different. We want natural looking skin, we want gradual rejuvenation, we want just barriers to better skin quality and no overcorrection. Now, in the paper entitled Consensus on Changing Trends, Attitudes, and Concepts of Asian Beauty, these are the four skin quality factors that a lot of patients ask for. They want even skin tone, meaning no pigmentation, no redness, no discoloration. They want an even surface, so they want to get rid of large pores, they want to improve their scars. They want skin firmness, such that when you do this, the skin goes back to normal, and of course, they want glowing skin. Now, talking about the first molecule that I use in my practice, polynucleotides, we know that they make up DNA and RNA in our skin. And what they essentially they do is that they sort of make the environment of the skin conducive to remodeling, such that when you do other procedures, like your energy-based devices or whatnot, you can get better outcomes. So I would like to think of this product as a priming agent, something that I do before treatments, and something that can regenerate the skin. Next ingredient is a hybrid cooperative complexes. So when I use this product, I think of hydration and bioremodeling. So this contains high and low molecular weight hyaluronic acid that's blended together. And because of that, it becomes a different molecule and more resistant to hyaluronidase. And its ability to stay longer in the skin is what enables it to stimulate fibroblasts, elastin, etc. So low molecular weight hyaluronic acid is somewhat more pro-inflammatory, whereas the high molecular weight hyaluronic acid is anti-inflammatory and is the one that hydrates the skin. The third ingredient that I use is PDLLA. So this one, I use this more when I'm thinking about collagen stimulation. So when you inject it in the skin, it's a foreign body, and because of that, it triggers inflammation, and therefore leads to fibroblast, triggering also leading to collagen formation, elastin production, etc. So usually when in my clinic, I have what I call the biological lanes. So when I want to repair and prime the skin, I use my polynucleotides. When I want to hydrate the skin and sort of do some sort of bioremodeling, nourish the skin, I think of my hybrid cooperative complexes. And when I'm more focused on collagen stimulation, I think of my PDLLA. So an example would be this type of patient. When a patient comes to me with reactive skin, thin skin, or something they want to do together with the procedure, I consider either doing polynucleotide or a hybrid cooperative complexes. So with this in mind, I start with control and not aggression. When a patient of mine comes with crepey skin, dehydrated with signs of early laxity, I think of wanting to hydrate the skin and to improve the snapping of the skin back to normal. This is when I start to use my hybrid cooperative complexes. So With this, I have elasticity and glow in mind. When a patient comes with large pores, dermal thinning, a mild laxity, my approach is to give collagen support. So in these types of patients, I use my PDLLA. When my patients have more complicated problems or a combination of different issues, for example, patient has melasma, texture problems, have dull skin. So usually I stabilize it first, meaning I give like proper skincare with antioxidants, tyrosinase inhibitor, sun protection, anti-aging, and then I might do a polynucleotide or hybrid cooperative complexes or both. Not always together, but can be together. Usually on these patients, I try to avoid inflammatory overload because as we know, inflammation can worsen melasma or any other pigmentation issues. Now when I have patients with acne scars and significant textural issues, so in these patients, you want structural dermal remodeling. So what I normally do is I do like a CO2 laser surfacing, for example. Maybe I do subcision and then I inject my product and I use them as adjunct treatment. So what we know reasonably well is that in our patients, you cannot really delineate the results, right? When you use your polynucleotides, it might look similar to the effects of your hybrid cooperative complexes and your PDLLA. But based on the papers I've reviewed, the hybrid cooperative complexes, they have a lot of papers published regarding the safety and post-marketing support. And there are reported improvements in hydration, elasticity, density, and overall skin quality. And I've seen it on my patients as well. For polynucleotides and polynucleotides with HPT, there are a lot of promising consensus-based and Asian-specific data and improvements on radiance, texture, elasticity, firmness, and even great patient satisfaction. For PDLLA, similar to your PN, there are encouraging evidence for hydration, elasticity, pores, wrinkles, and benefits are said to be gradual, meaning you don't see them immediately after injections. Usually your patients would have to wait a few months to see results. So what we should not overclaim. So unfortunately, there are no perfect head-to-head trial which compares all three. So you cannot really say that one is better than the other. What I normally tell my patients is that you really won't know how your skin reacts until after you've tried it. So if I have patients who don't know what they want, I try to identify first the main issue, and then using my biological lanes, I recommend a treatment. But it doesn't stop me from maybe trying the other treatment if I don't see results with what I've chosen for them. So now we go to my cases. This is a patient with dull textured skin and even pigmentation, some acne marks, and who claims to have reactive skin. He kind of likes to go outdoors. In fact, the after photo was taken 2 or 3 weeks after he has gone to the beach. So as you can see, improvement in overall tone of the skin. He initially had redness, blotchy pigmentation, but after 2 sessions of the polynucleotides HPT, there's improvement in overall tone, even how the skin feels and how the texture of the skin after the treatment is better than baseline. So this is a patient of mine on whom I use the hybrid cooperative complexes of hyaluronic acid. Initially, when she came to me, I refused because I told her, you know, I think you need something more aggressive, maybe like a resurfacing treatment or something that ablates the skin, but she refused. So I offered the hybrid cooperative complexes, staying, managing expectation, but I was really surprised with the results. So this is a good responder patient. So not all patients will result to this kind of effect, but I realized that hybrid cooperative complexes work well on crepey skin, those with loose, lax skin, dehydrated, dry skin. So this is after 2 sessions. You can also use it on patients with dull, dry skin with visible pores. So this patient has, he complained about always having like red patches on the sides of the nose, visible pores, and I couldn't really offer him anything else because he tried everything already. I offered him the hybrid cooperative complexes, and it resulted in glowing skin and less visible pores. And finally, for PDLLA, this is a patient who came in due to dull lackluster skin, textured skin, fine lines, wrinkles. Her issue is she loves to go outdoors and is looking for a treatment that is suited to her lifestyle, meaning no downtime, nothing that would require her to stay out of the sun for longer than 2 weeks. And so I tried 2 sessions of PDLLA, and it led to like more glowing skin, improvement in texture. It's really more like how it feels rather than how you see it. But patient was very happy. And if you notice as well, there's a little bit of improvement in the marionette lines and the nasolabial fold. So usually what I do, technique and interval pearls, for my polynucleotides, I might inject it superficial into the dermis intradermally, or I could use a cannula to deposit the product subdermally. Usually, I recommend 3 sessions, 2 to 4 weeks apart. For the hybrid cooperative complexes, I use needle. I inject it deep dermally or subdermally, and I use the 5 bioremodeling points on each side of the face. For the PDLA, depending on the formulation, I might use a needle or an injector, or I could use a cannula and deposit it in areas that need structural support. I also like combining it with energy-based devices. So if patients have pigmented or reactive skin, I make sure that I do pigment control and barrier reinforcement first before I combine it with other products. So for patients with this type of skin, control of inflammation is very important. For texture and scars, I use a more aggressive treatment like RF microneedling or CO2 lasers. And for those with collagen loss and laxity, I do the injectables first before I do my treatments. So minimizing complications, these are the things that you have to consider in skin of color. And for my final algorithm, I like to diagnose a dominant skin quality deficit first and then decide based on my biological lanes which injectable I will use. So for my takeaways, so PN, PNHPT, think priming and repair support. For hybrid cooperative complexes, think hydration, bioremodeling. For PDLLA, collagen stimulation. And in skin of color, sequencing and inflammation control matter more than aggressive stacking. So in clinical practice, layered protocols can be useful because each class targets a different biological deficit. So these are my references, and thank you for listening.
Thank you, Roberto Vitas. So next speaker is Young Ko from Korea, a dermatologist. His topic is polylactic acid dermal filler enriched with the incube encapsulated antioxidants. Dr. Go, please.
Okay, thank you for introducing me. My name is Go Young-woo, and my clinic name is Milo Dermatology Clinic, located in Gangnam District in South Korea. So, as a dermatologist, my patient want some volume production, such as hollow cheek or hollow forehead. So, in this point, I usually use many kind of skin booster, something such as PLLA or PDLLA. So today, I'm going to talk about PLA dermal filler enriched with incube encapsulated antioxidant. So as you guys already know that conventional collagen skin booster such as PDLLA or PLLA have some acute inflammation. We call it early spike. But there are some questions because every patient have some worries about adverse side effects to unwanted, such as granulomas or unwanted volume production. So, in my opinion, or some questions, often acute inflammation really necessary. So, our treatment goal is think a moderate inflammation responses, controlled remodeling patterns. So, I told you before, uncontrolled inflammation leads to various moderate, severe complications, such as nodules, granulomas, edemas, swelling, persistent erythema. So, moreover, histological studies increasingly show that inflammation-driven fast collagen often has irregular fiber organization or fibrotic morphologies. So, rejuvenation should not require excess inflammation, but create conditions for sustained remodeling. So, in my opinion, this research conclusion is very interesting because PLA plus vitamin C plus glutathione is mixed with together and inject into combination. So there's some more effect and less inflammation. Okay, let me see the result now. They called it in-cube antioxidant enriched PLA. As you can see this, PLA used without antioxidant shows strong inflammatory reactions in early stage. This one means blue graph, and gradually decrease, which can cause side effects such as nodules or granular mass. On the other hand, the red graph, PLA-contained antioxidant shows a stable patterns. And about collagen inductions, PLA-containing antioxidants shows higher collagen production than regular PLA. Polylactic acid enriched with in-cube encapsulated vitamin C and glutathione. This is preclinical evidence of superior collagen induction and tissue response compared with the conventional PLA. But as you guys know it already, vitamin C and glutathione is very fragile thing. So when I try to some cosmetics using vitamin C, it's very hard because in sterilization stage, vitamin C is very easy breakdown. So it comes to loss of efficacy. And it has vitamin C and glutathione are excellent in promoting collagen synthesis and antioxidant effect, but they decompose very quickly. So within aqueous solution or general polymer matrices, making it difficult to maintain long-term effect. So in this experiment, a technology called Kubrick's, Kubrick's means some kind of structures, use of MOFs. MOF means metal organic frameworks, which won the Nobel Prize in chemistry last year by a company called LabinCube, encapsulated and protected all antioxidants to secure accurate experimental data. In my opinion, I don't know why almost all patients in my clinic scared about some kind of filler injection, something such as HA filler or PLLA, PDLLA fillers. So I think this technology is very good to some kind of scary or reducing some side effects. So that's all. Thank you for listening.
Thank you, Dr. Go. Our last speaker is Dr. Trisrang Limpaibun, is Thai dermatologist. She'll present about a comparative evaluation of mechanical projection versus biostimulating remodeling in superficial middle face lifting, a preliminary prospective studies.
So, good afternoon, everyone. I'm Dr. Tisulang Limpaibun from Bangkok, Thailand. It's honored to be here, and today, thank you for joining my section. When we talk about the mid-face lifting, we usually focus on the outcome, but actually create the outcome with the From the projection and volumizing from the HA filler, is the volume and the projection from the HA filler, or the collagen stimulation and the tissue remodeling from the biostimulator. Today, let's compare the two approaches. So we decided to sample the study. We compare the HA filler and the PCL plus the CMC to see how is the treatment that create the lifting on the mid-face. The outcome evaluated by the using the objective 3D image. So we used 20 Thai patients with the mid-face aging and the separate to two groups. So we treat with the same technique but the different product. The first group we use the HA filler and the second group we use the PCL plus the CMC. Into the same volume, total I use the 1 saline per case. And then we evaluated the lifting effect by using the quantifier 3D imaging. Okay, let's start with the HA filler group. We selected a high G prime HA because of this strong projection and lifting capacity. You see, I choose the 1600 G prime. As you know, the high G prime can create more lifting capacity by without using a high volume. In this group, the lifting effect was expected to the result from the volume and structure support. So we select the filler because it provides strong projection and structure support. There are the strong HA, the combination with the minimal BDDE, with the active cross-link for the good support and the good safety. For this, it was used our model for mechanical lifting. Now let's move to the regenerative part. So you can look at the PCL plus the CMC group. The product works different from the HA filler. The PCL is the porous PCL regenerative collagen biostimulator, but the component has the 30% of the porous PCL plus the 70% of the CMC. The lifting effect comes from the collagen stimulation and tissue remodeling over time. So how does it work? As you can see, the post-injection, the CMC gel provides the support the volume after injection immediately. And you can see 4 to 6 weeks, CMC gel are absorbed to the skin, but the PCL starts biostimulation and collagen production. Then the collagen form around the product. It can create the lifting effect, as you can see in the picture. So the method, I use the cannula 22G fanning on the technique 0.5 per side on the mid-face area into the subcutaneous layer by delivery this product. The first group, 10 people, I use high G prime and high G prime of the HA filler. And the second group, I use the PCL plus the CMC for 10 people too. Let's see the result. Okay, you can see the result is the left side is the baseline, and the right side after 1 month and after one treatment is visible the lifting and the better facial contouring, as you can see. So when we look at the 3D analysis, we found something interesting. We didn't see a large increase in the volume, and you can see in the red circle it showed the decrease the volume. The volume decreased 0.16 mil, but we still saw a lifting and the contour improvement. Here is another patient. We observe a similar pattern. At the 1 month, and the face looked more lifted and better defined. Again, we didn't see a significant increase the volume, but they continue to see the contour, the improvement and lifting. In the red circle, total volume are decreased 0.26 mil. It means they are lifting by without the increase the volume. For me, it was interesting to finding in from study. So now look at the HA filler group effect. As expected, we see the more projection and support after treatment. The lifting effect comes from the restore the volume in the midface. You can see in the area, the red area, it means the volume up together from the lifting effect. When we look at the 3D analysis, we saw a clear increase in the volume on the midface area. This is the volume increase in the red circle total increase 2.4 mil. They are associated with the visible lifting effect, as I told you before. So let's look at another case. As you can see, in the midface appear the better supported and more divided. What the interesting, we didn't see the more the volume here, but we see the nice lifting effect, but after treatment. There are the before on the left side and the right side after one treatment and after 1 month, as you can see from the picture. Okay, when we compare the two groups, both PCL plus the CMC and the HA filler show the lifting effect. Both groups look more the lifted after treatment. The interesting part is how they create that the lifting effect. For me, this was the key message. A lifting effect doesn't always come from the add more volume. This is a maybe different way to create the same result. So we also look at the skin quality. For this case, I use the PCL plus the CMC at the 1 month. What is interesting that after 1 month, you can see that in the left side is parameter baseline and the right side is the after one treatment and after 1 month. We saw not only a lifting effect, but also the improve in the skin quality. The skin look healthier and more refresher overall. As you can see, we observe in the improvement in the severe parameter. The skin looks smoother, healthier, and more refresher after treatment that you can see. We saw the same trend in other patients as well. Not only lifting, but also the improve in the skin quality too. In this case, I'm very interested for the problem is the evenness and oiliness. They are better in 1 month. So when we put everything together, both treatment gave the lifting effect. But HA filler create lifting through the volume and structure support. But the PCL plus the PCMC created the lifting through the collagen biostimulator and tissue remodeling. The last one, in my opinion, there is no single product that fit for everyone. Every patient has different concern and different problem. The key is to choose the right treatment for the right patient. And the outcome from the doctor experience and doctor assessment. Thank you. ขอบคุณค่ะ
Thank you, Dr. Limpa Ibun. So, would you sit here? Yeah. Is there any question or comment from the floor? Okay. So, I'd like to add to Diane. It is not familiar to us as a PGLA product in Asian. So would you explain that product and what kind of things we can expect it compared to the biostimulators or HA fillers?
Well, technically, it's a biostimulator or a skin booster, but the PGLA is an FDA-approved. Basically, it's a vehicle for drug delivery, and so there are many forms of it, and a lot of the pharmacies will get PGLA from a certain FDA-approved mass manufacturing lab, and then they can load it, kind of like a liposome. You know how you can load liposomes, or even in some places early work in loading exosomes with specific signalers. This will actually, we had that talk earlier about matrix and how the exosomes, et cetera, are cell signalers, but you also need something that has a matrix structure, like matrikines. And so you can load structural elements. This particular one has a small amount of collagen 1, but mostly collagen 3, depending on the version that you get. But it's a sustained release. And most of the skin boosters or biostimulators that you inject basically are absorbed in the interstitial fluid, and then you don't have sustained pulses of release. But this particular one, you'll get collagen deposition in the same injected region over a 3-month period, because the breakdown of the carrier is a combination of glycolic acid and lactic acid. So if you imagine that glycolic acid is going to resorb or undergo degradation a little bit more quickly than the lactic acid, you've got a carrier that becomes perforated with little holes, and that's how you get the aggression of the collagen over time. And basically the carrier does break down over time, and at the end of 3 months it's gone. So a little bit like a filler, but instead of getting the effect all at once, then it's over 3 months. And so if you want something that gives 3 months worth of a message, you know how we sometimes will treat somebody once a month times 3, they would only have to get 1 injection.
Thank you. I'd like to ask about PDLLA, PN, and HA. What is your definite criteria to choose the kind of skin boosters or stimulators, biostimulators?
It usually starts, doctor, with the basic skin issue that my patients are dealing with. Because when they come to you, they give you like a general complaint, like, oh, my skin is dull, I want it to look good. But usually, when the skin is on the dry side, I prefer to use the HA complexes because it gives them an immediate hydration. Like in a week, you see improvement. If the patient wants to combine, say, the injectable or plans to do like an energy-based device treatment or surfacing or whatever, I like to use polynucleotides because in my experience, it is a good priming agent, and it even...
HA has a lot of kinds of HA.
Yes, also the hybrid cooperative complexes is the one I use. I use the high molecular weight and low molecular weight cooperative complexes. That's the one I use, the HA. But for patients who are planning on doing like a laser surfacing, for example, or like a more aggressive treatment, I like to prime my patient's skin with polynucleotides. I believe that it has a good regenerative and reparative capacity, so that when I do my PN, 2 sessions, 2 or 4 weeks apart before I do my energy-based device, it gives them good results. When my patients are in need of some form of tightening and addressing skin laxity, I find that the PDLLA or even PLLA works for that. Depending on the structure, I may inject it using a cannula in the subcutaneous layer, temples, here and then here. Or if the patient is quite young, I might use a sort of lower concentration and lower, how do you say it, smaller particle size and inject it intradermally. But like I said earlier, it's not like set in stone. Some patients, even if they have dry skin, do not respond adequately to the HA complex, and then I would try the others.
You usually injectable first,
Yes.
and then
Yes.
EBD, right?
Yes.
How about an interval? between the injectable and EBDs?
So if my goal, doctor, is to prime, usually week 0, I do my first injectable. Week 2 to 4, I do my second injectable. And then after 2 to 4 weeks, I do my energy-based device. But, you know, in the Philippines, especially during the holiday season, we have patients who come in and they're there for like 2 weeks. So there are instances wherein I combine all of them together. I do my energy-based device first, as long as it's like, you know, non-invasive, or like laser toning, for example, or like a mild fractional laser peeling, and then I do my injectables after. So that also happens, but if I had time, I would prime the skin first with the injectables before I do my energy-based device.
Yes, in INCAS Asia 2026, the issue was the prime and EBD, right? So we don't know the exact interval between them, but many doctors recommend a more interval between them. It's 1 or 2 weeks is
Short.
short.
Yeah, because collagen remodeling takes about a month to 3
Yeah.
months. I agree.
No, I think we were talking about this in another session, and 1 month was the consensus. But you know, your patients may not have that time, so
exactly.
I think you do the best you can with what you have to work with.
Our patients are quite impatient.
Yeah, yeah. Asian patient, every Asian patient. So, Dr. Go, I don't have any experience about this product. So this is a PDLLA plus vitamin C and
Yes.
glutathione only.
Yes,
In
actually,
a product, explain they have a PN also.
now PN
No.
just uh, it called just structure.
Oh,
PLA structure is the molecular structure and mixed with vitamin C and glutathione. So actually, this is not approved yet in Korea. So this is
Oh.
only experimental
Mm.
thing. So
Oh, that's
so,
why
yeah,
I
yeah,
didn't
yeah.
know that.
That's why you don't know yet.
Yeah. Okay. Uh, my last question is to Dr. Lim Pai-bun. Is it too short? Result is only 1 month?
Yes, because no more time for the because PCR plus the CMC in Thailand, Thai FDA approved around 1 to 2 months.
Oh, really?
Yeah,
Oh.
it is short
I
time.
think after 1 month, definitely HA is more stronger effect than PCL, right? PCL, PDLLA, PLLA usually have good result for a long time, or 3 months or 6 months.
But I use the PCL plus the CMC. I want to create the lifting for the compare to the HA filler and need to learning about the skin quality.
And also your patients are so young. Okay, is there any question or comment?
Hello, good evening. So my question is for Dr. Duncan. This was new for all of us, I think, you know, all the regenerative fillers that you talked about. So are they in production, or are they just, you know, like experimental, you know, the ones that you mentioned?
I didn't quite catch the last part. Can you slow down and repeat?
Yes, ma'am. So, ma'am, the products that you talked about for the anti-aging,
Yes.
so are they in production or are they experimental?
Yes, they
Yeah.
are in production.
Okay.
So if you meet me at the door after we're done, then I can let you know, this is CME, so I can let you know
Yes, understood.
where to
Got
go
it.
for it.
Okay, thank you so
But
much.
yes, currently available.
Okay. We have a little time, but this is the last session. We have to go home. Diane have to go home so far. Is- how long does it take?
22 hours.
22 hours. Thank you for coming, and thank you all of you and all our speakers. Thank you.